So good morning, everyone. Um, Today I'm presenting on a nuanced topic, stress echo in the setting of pulmonary hypertension. The goal will be to kind of go over pulmonary hypertension in as it relates to echo and echo findings, and then what stress echo can add to it. So no conflicts or relevant disclosures. So as I discussed, the objectives are to review the principles of stress echo. There have been two other talks already on stress echo, and so I'll just kind of very briefly go over it, just to kind of orient us to when we talk about how stress echo pertains to pulmonary hypertension assessment. Then we're going to review the transthoracic echo findings of pulmonary hypertension, and this will serve as a foundation to further understand what stress echo can add to that. And then finally, we'll look at how does stress echo fit in the overall paradigm of pulmonary hypertension diagnostics, because as you can imagine, there's other modalities, and this is usually an area, depending on what center you're at, there's overlap between cardiology and respirology. And so we'll talk about our role as echo in the bigger scheme of things. So today's talk is primarily drawn from three guidelines, two of which are echo, and you probably are familiar with. One is the non-ischemic heart disease stress echo guideline, where it talks about all the indications for stress echo non-ischemic related. One is pulmonary arterial hypertension. So this is just regular transthoracic, how we can use it to further assess pulmonary hypertension. And then the next guideline you may or may not be familiar with. So this is an ESC guideline. It came out in 2022, and it's very comprehensive in both diagnosing pulmonary hypertension, but looking at the echo features. And so I drew quite a bit from that because it's also got the most up-to-date information compared to the other two guidelines. So just a little bit of history on stress. We do it quite often now, but that wasn't always the case, and it wasn't always what it is today. So stress echo first came to life in the late 1970s in the U.S. At Indiana University, and this was just experimental. And at the time, they used a bicycle. And it was only 2D images, and they only have 3D scanners. And so the clinical question at the time was, is there exercise-inducible wall motion pre-surgery, and is it resolved post-surgery? So at the most rudimentary level, it was assessing for ischemia, and it was using a bike. After this, these are the images that were published in the landmark paper by Wan et al. After that, it kind of died down, and it really didn't come back until the mid-'80s, so like about 5 years later. And the biggest reason was that people found it difficult. The programs and the ultrasound machines weren't set up to compare pre and post, and so it was kind of, you had some pre-pictures, and then on a different setting, you have a post pictures. And for everyone in the room who does stress, you know how nice it is to have both side by side, because you can really see and compare. And so it kind of died off, and then it slowly picked up, and then it developed into what it is today. Why do we do stress, and what's the benefit of stress echo? The idea is there's a lot of physiologic changes that happen to the heart during stress, and one of the ideas or the thoughts is that different valvular pathologies, different cardiomyopathies, different cardiac conditions, as well as pulmonary conditions, are augmented by the physiologic changes that occur during stress. So what exactly am I talking about? So in a normal patient, in a healthy patient, we expect your heart rate to increase by 2 to 3 times. Contractility is going to increase by 3 to 4 times. Your LVM and diastolic volume increases, and your stroke volume increases. And so what this results is there's higher wall stress, so there's increased oxygen demand by the myocardium. There's increased pulmonary artery pressure, And this is important when we discuss in a little bit, it's why I'm bringing this up. This is important when we discuss exercise-induced pulmonary hypertension, because in normal individuals, you do expect a slight increase, a physiologic increase. So it's kind of teasing out what's physiologic and what's abnormal. And then coronary artery blood flow should increase by 3 to 5 times in normal subjects. Most people are probably familiar with the different protocols in the room, but just for a comprehensive overview, there's 2 main protocols we use, at least here at St. Mike's, and they're dependent on the modality of exercise. So one is treadmill and one is bike. There's different pros and cons to each, which I'll touch on a little bit throughout the talk. But one thing you'll know is that based on the protocols, the grading of exercise and the METs achieved are slightly different. And that obviously results in the degree or the ramp up of physiology can be different between the two. So how to stress, again, something we're pretty familiar with, but just for some people who may not be online or even in this room, I like to think of it as basically there's a couple of different ways we can stress the body. Exercise is the most physiologic or normal, and then there's pharmacologic. In different centers, you'll see different things, and there's obviously pros and cons. Regarding the treadmill, there's a lot of familiarity with it. The exercise stress test protocol for regular exercise stress tests are fairly well known. And in smaller centers that may not have a bike, you can already use an existing equipment. And so that's kind of the pro of that. The bike is a little awkward, as I'm sure everyone who's known has done stress, especially for the patient to keep the cadence and keep their coordination going. But as you also know, it's great physiologically because you can get images in real time. And when it comes for measuring pulmonary artery pressures, we really want to know what are their pressures at peak exercise, because oftentimes patients will say, I have dyspnea when I'm exercising. So in order to really understand what's happening, you want to capture the measurements at that point. Pharmacologic, we are all familiar with. So dobutamine, basically, you increase it in doses, usually from 5 to 20 mics. It can go as high as 40, except for in the AS protocol. And then vasodilators can be used. We usually use adenosine, but there's other agents that can be used. Regarding the image acquisition, this is where teamwork between the sonographer and the supervising or reading physician really comes into play, because I'm sure, as you guys know, depending on the clinical question, you're going to want to image certain parameters either earlier in the study, later in the study. Depending on what you're looking at, you might image more, for example, tissue Dopplers than not. So this is just kind of how this talk fits in the overall clinical utilities of stress echo. So there was a previous, Flora, one of the other fellows 2 years ago, gave a talk on ischemic related stress echo. And so that's really looking for contractile reserve. It can sometimes be asked, is there viable versus hibernating myocardium? And sometimes it's done in high-risk patients to assess for the presence of cardiac disease prior to going to non-cardiac surgery. A year ago, there was another talk by another one of our fellows on non-ischemic cardiac indications for stress echo. And that's where the majority of this was, except for that last little bit, which is pulmonary hypertension, which is what I'm going to discuss. So as we commonly will see, because we're a big valvular center, in terms of assessing severity, mitral pathology, aortic stenosis, stress echo plays a role. HCM for looking for inducible gradients. Congenital defects, we don't do as much, or just because we're not a congenital center, but just so that everyone's aware, there's a couple of different things you can look for. In patients with atrial septal defects, you can look for RV performance. You can look post-surgical tetralogy of Fallot, a treated cohort, or even a systemic RV. Diastolic dysfunctions is another one. And then last is pulmonary hypertension, which is going to be the focus of today. So I just wanted to bring it back to a case. And this is a case saw a lot during internal medicine and cardiology. And so it's a 53-year-old female who presents with dyspnea. Her past medical history includes obesity, her BMI is roughly 30, hypertension, diabetes, ex-smoker. She tells you that she's got quote unquote mild COPD, but there's no PFTs anywhere on file, and she's on some peppers. And her history is that she is short of breath with any activity, walking, stairs. There's no associated chest pain or palpitations. She doesn't get any dyspnea at rest, and it's quite chronic. It's been going on for a year, but she says, I just can't exercise. I want to lose weight, and I can't because I'm so short of breath. Physical exam is pretty unremarkable. She has some mild bilateral pitting edema, which could be due to venous stasis or something else, and her JVP is borderline elevated at 5 centimeters. Okay, so by the time the patient has seen you as a cardiologist, she's kind of bounced around a little bit. So that was the first referral. By the time you see her, she's had an exercise stress test, and it was kind of unremarkable. She wasn't able to get to target heart rate because she was so dyspneic. And then she went and saw a respirologist, and her PFTs were done, and there was some mild obstruction, but it didn't explain the level of dyspnea. And one physician told her she just needs to lose weight. And this is something we see a lot because dyspnea is really nonspecific. And I think that's where exercise-induced pulmonary hypertension can really help delineate some of this nonspecific symptoms. She's 53, she's young. If she had a reversible cause or something where medical intervention could benefit her, it would really be helpful. And just chalking it up to obesity or lack of fitness isn't always helpful. So what is pulmonary hypertension? So it's defined as the increased mean pulmonary artery pressure greater than 20 millimeters at rest, and it's usually assessed by right heart catheterization. We all today in this room work at a tertiary care center where there's readily access to cardiac catheterization. If you're working in the community in a rural setting as an internist or a cardiologist, you often don't have easy access to this right heart cath. And so while this definition is all well and good, for the patient that I just presented sitting in front of you, you're kind of left scratching your head, well, I can refer her for cath, but it's going to take goodness knows how long. And that's where the role of stress echo comes in. And so just a little bit more about pulmonary hypertension from a global perspective. It affects about 1% of the global population. The reason it matters is over time, you can see on the bottom here, as your mean pulmonary artery pressure increases, your mortality increases. And why this is important is because it leads to right heart failure. And as we know, over time, we have less that we can do for right heart failure, especially in the absence of valvular disease or, for example, an MI. So that's where there's really a unique place for intervention, because if we can diagnose this, then we can hopefully then treat it. Pulmonary hypertension is grouped into 5 different classes, and the treatment is based on which class you're in. And so in our echo world, the big thing will be kind of trying to identify it, but just to understand why this matters and why it's important, I'm just going to kind of go through the 5 different, and you can see what's rare and what's not rare. So pulmonary arterial hypertension, these are the ones that are younger. It's pretty rare, but the reason it matters and why it's important to try and identify it is we have drugs. We have drugs that we can use. They're expensive, but we have drugs that we can use to treat these patients. And some of them, if they're young and don't have other comorbidities, could go on to lung transplant. Patients that we are probably very common seeing with pulmonary hypertension is the ones that are associated with left heart disease. These are a little less interesting, very common in our population. They're a little less interesting in that the significance of diagnosing their pulmonary hypertension, especially from an echo perspective, may hold less weight, because at the end of the day, it's due to their left heart disease, and what you're going to do about it, it's a little bit less limited. So if somebody has known left-sided heart disease, doing a stress echo for pulmonary hypertension may be lower yield, because again, it always comes down to what are you going to do about it, and not very much. The same goes with lung disease, also quite common, not as many drugs. There are two other rare causes, one of which actually echo does have a role. So CTEPH, which is chronic thromboembolic pulmonary hypertension. And so this is related to if you have a chronic PE, you can develop pulmonary hypertension. This is important to identify because we have surgical interventions, medical therapies as well, and sometimes these patients can be young, and so in terms of mortality, there is quite a lifespan that we can intervene on. And then there's rare causes. These are related to systemic disorders, hematologic disorders. Again, less high yield because we don't have as much we can do, but still important and an evolving area. So from a transthoracic perspective, there's actually quite a lot we can figure out from diagnosing pulmonary hypertension. And this table comes from the ESC guideline in 2022. And I'm gonna break it down. This is a busy slide, so I'm gonna break it down. And these are parameters that are used to help support pulmonary hypertension, but then we're gonna talk about what do we put the most weight on. So some things we're probably all familiar with that we've seen. So an enlarged RV, specifically looking at an RV ratio. So a dilated RV with a basal RV to LV ratio greater than 1 in the 4-chamber view. The flattened septum or D-shaped septum is something we're commonly seeing in our short axis view, and a dilated IVC with diminished inspiratory collapsibility. Now, obviously, there's other reasons that you can have these echo findings, but if the question is pulmonary hypertension, even in a transthoracic echo, these are views you want to try and get, and these are things you're hoping to either measure or display. Some other things that are a little bit more nuanced, but can definitely help more when trying to tease out, is the RVOT acceleration time. Less than 105 milliseconds is often indicative of precapillary hypertension. The other thing is an RV fractional area change. So less than 35% is considered normal. And it's basically measuring, it's kind of like an LV Simpsons, but you do it for the RV. TAPSE is routine part of our protocol. So TAPSE less than 18, and then a peak systolic RVS prime less than 9.5 centimeters squared. The thing with these is that, except for the number of E's, they're all measures of RV dysfunction. And the thing is, as you saw in the earlier slide, RV dysfunction is a later finding of pulmonary hypertension. And so while these are good ancillary findings, we'd like to see if we can pinpoint something that even picks it up before this end stage progression. So a couple other things. And this is kind of getting to the meat of what's important. So an enlarged right atria, greater than 18 centimeters square in the 4-chamber view. Peak TR velocity. So an increased peak tricuspid regurgitation velocity measured with continuous Doppler, greater than 2.8 milliseconds. That's the number to remember. And that in turn allows us to measure our estimated systolic pulmonary artery pressure. And then the last is a presence of a pericardial effusion in either your 4-chamber or your short axis view. So this is how, using all those, so as you saw, there's many findings, but if you're asked the question of, does this patient have pulmonary hypertension, from an echo perspective, the ESC recommends this as being the guideline, or this as being the flow chart to go about how you use as a starting point to know, is this patient have low, intermediate, or high probability? So if you are referred, the first thing you want to look at is tricuspid regurgitation velocity. And the reason I said that is because those other things, the dilated RV, those are all later findings. And so 2.8 is the kind of threshold number to remember. If it's less than 2.8 meters per second, the likelihood of PH is pretty low, especially in the absence of any pulmonary hypertension signs or symptoms. If you have the 2.9 to 3.4 category, this is where it's a little bit more intermediate. And they recommend echo follow-up. And usually this is where you'd have somebody else involved who either has a clinical pretest probability of pulmonary hypertension, whether it be a respirologist or a cardiologist. And then 3.4 is when you go, okay, this is pretty high, and that's actually a class 1 indication for right heart cath. And the reason this is helpful and important is that, again, depending on where you are, if you are in a peripheral center and you think the patient might have pulmonary hypertension, an echo can be a good screening test, and it can also be a way to get your patient onto a right heart cath sooner. Studies show that most patients with pulmonary hypertension show at least moderate TR when there's this, with a systolic pulmonary artery pressure greater than 60 millimeters of mercury. Okay, so this is just kind of illustrating, these are just some still images, illustrating what we already saw. So here you the actual images. So on the left, you have a 4-chamber view where it shows severe RV enlargement, and then on the right, you have dislocation of the interventricular septum towards the LV. And then here on the transthoracic echo, you have a Doppler tracing of the TR showing severe pulmonary hypertension. So our TR velocity is greater than 5. Remember that 2.8 is that threshold and marked by this arrow, and then a dilated RVC in your subcostal view. So interestingly enough, there are some prognostic echo markers of poor outcome in patients with pulmonary hypertension, and they're not exactly what you would think. So some of them make sense, like the degree of septal shift or the tricuspid annular plane systolic exertion, but some are a little bit different. So in fact, the presence of a pericardial effusion or an enlarged right atrial area have poor prognostic markers. And this comes from the ECHO guideline on pulmonary hypertension, which compiles a bunch of different studies looking at patients with pulmonary hypertension and how they assessed for severity, and then the follow-up. And that's basically how they came about with these prognostic markers in terms of poor outcomes. Okay, so now we're moving into exercise-induced pulmonary hypertension and where stress echo can play a role. So what I alluded to earlier is physiologically, there's going to be an increase in your pulmonary artery pressures, and that's normal during exercise. And it's called pathologic when there's an increase beyond what's considered physiologic or what's normal. And so the question is, what is normal and what do you deem as pathologic or physiologic? What pathophysiologic, sorry. And the reason is it kind of varies depend on your age and your other parameters, especially if there's concomitant heart disease. So we know that there's a mild increase in pulmonary artery pressure that's linear with an increase in cardiac output. And this has to do with dilation of compliant small vessels and or the recruitment of additional vessels in the upper portion of normal lungs. So I found this study, which was kind of interesting, which was basically saying that there, as you increase in age, there's going to be a progressive increase in pulmonary artery pressures. And it's actually age dependent. And so at a younger age, you'll have less of an increase. And then as you age, you actually have more of an increase in your pulmonary artery pressures. When it comes to performing the stress echo and what we look for, this is where understanding what views we take and when really matter. And this is all part of the protocol, but just to kind of give a refresher, the most important thing, I think, and we can have a discussion about it later, is your TR velocity. And getting a TR velocity at rest, and then getting a TR velocity at peak exercise, and then in recovery. The challenge is that sometimes we don't always have a good signal. And that's where, and I have an example later, but that's where saline contrast can help bring out the TR signal. So this is technically the protocol that is in the guideline, and basically what it says you should do is you should the type of stress is exercise, so pharmacologic doesn't work here. The sequence of image acquisition matters, so you want to get the TRCW, Doppler for the systolic pulmonary artery pressure, and then the RV views. What's also important is to get a baseline, a low, like intermediate level, and then a peak exercise. This is why the bike is preferred. And as you guys can all imagine, with the bike, you can get measurements in real time. And so that's the benefit of doing a bike versus the treadmill. In terms of what the guidelines say, they actually don't give a hard and fast number of what they define as exercise-induced pulmonary hypertension. And I was kind of looking, and that's why I showed you the slide earlier, is it's really age dependent, because the older you get, you're actually going to have a larger increase. And so it's one of those things where I think it's an evolving area, because we don't, like, it depends. If it goes up by 10, is that significant? If it goes up by 20, that's significant. It kind of depends on age. And I think I have an example I'll show you is really what you're looking for, a delta. How much does it go by? And can you correlate that to their symptoms? And do you see ancillary findings? So does the TR velocity just go up, or do you see RV dysfunction? You're looking for other things as well. Okay, so this is an example. Sorry, it's a little fuzzy. So basically, the first is trying to get a TR signal at rest. And you can see it's very fuzzy, very faint. And this is actually, I think, pretty indicative of real life. Patients come in and we go, I don't have enough TR, I can't really get a signal. And if you don't have a baseline signal, it's very difficult to know, well, what was their TR velocity at rest? And I would argue that the study is kind of null if you don't have a baseline, because you need to know what your baseline is. So one of the things you can do is you can inject agitated saline. And what you'll see on the right-hand side is you'll actually see you're now able to get a measurable TR signal. And now you're able to see where the peak TR velocity is, and you can proceed with the study. You can imagine that if you thought, if you just went with this and you said, oh, well, there's really no TR, you could place the peak velocity there, you could place it there. I mean, that's not bad, but that is still not where we're actually going to measure it, which is down here. So that's like a very important starting point before you go forward. The next thing you're going to do is you're going to stress the patient, and you're going to take an intermediate and you're going to take a peak. So this patient was able to get to 75 watts, and you can see that there wasn't much change between the 50 and the 75 watt measurement. The other thing that's important to note here is that because your TR velocity is squared to get your estimated pulmonary artery pressure, it's very important that you, as accurate as you can, measure it, because any measurement error is going to be squared. So it's going to be multiplied by itself, and it leads to disproportionately higher degree of error. This is one of the reasons why this is not the gold standard, and clearly a right heart cath is. But if we come back to our case and we're trying to kind of keep as a gateway of what patients do we get referred to sooner, what patients do we have a better understanding, these measurements do matter. Okay. And this is kind of what I was just saying. So there can be underestimations of pressures for a variety of reasons. This is not a perfect measurement. And so there's some things we can do to help alleviate some of the underestimation. So the TR velocity should be measured in multiple views. And as we know, it should be parallel to the color Doppler because it is angle dependent. The RAP is estimated based on standard criteria using the inferior vena cava, and there can be a degree of variability with that as well as visualizing it. So also something important. The challenge is that there's an assumption made that there is a constant RAP at rest and exercise. So we measure the IVC at rest, right? We're not measuring it at exercise. And it's hard to know what is exactly happening to that RAP pressure during exercise. And as you know, we add that RAP pressure on. So if during exercise the RAP increases, we actually might be falsely assuming what the systolic pulmonary artery pressure is. And the reason is just to understand why there may be discrepancies in what your echo finds and what your right heart finds. And then that's kind of like the last point that this may not truly reflect what the RV and the RA is seeing in terms of pressure gradients. Okay, so I just want to go back to our case. Just as all to refresh everyone. So this was our patient, very nonspecific symptoms, was told that she just needs to lose weight. And this is what her echo ended up doing with exercise. So her RVSP went up dramatically. It went from 39 to 78. And she's young. So if you remember on that pink curve, you would expect a big increase in RVSP with older people. Big is again relative, but she's 53, so she's kind of on that lower end. So this is almost doubled in the setting of exercise. Her heart rate went from 70 to 130. And in addition to a TR velocity increase, you see significant RV dysfunction with exercise. So this would be considered positive for exercise-induced pulmonary hypertension. A little bit more on diagnosis, because you have this. How does this fit into the grand scheme of things? And this was kind of the last bit of the talk I wanted to kind of discuss was where does stress echo fit in the diagnostic schema. So it is recommended that in addition to an echo, patients should get a standardized 6-minute hall walk test. Biomarkers including a BNP and renal dysfunction, possibly cardiac MRI. There's no debate, though, the gold standard is cardiac catheterization. And so you might say, okay, well, that's well and good, but what clinical scenarios should I be ordering an echo in my patient? And that's where I think the ESC guideline does a great job of specifically giving situations in which there's actually class 1 indication for echo. And in doing this talk and reading the guideline, I was surprised that it's actually recommended more than I would have thought. And maybe we are underutilizing echo as a screening mode for pulmonary hypertension. So just walking us through this. So one of the things we are probably all familiar with is it's recommended to assign, recommended in patients where you think might have pulmonary hypertension. And that kind of gateway is the identification of an elevated TR velocity greater than 2.8. And of course, this matters in the setting of other signs and symptoms of pulmonary hypertension. But what should also be known is in some of the other causes of pulmonary hypertension, and you remember the 1 to 5 WHO classification, there's actually specific indications for echo. So in patients with liver disease or portal hypertension with signs and symptoms of pulmonary hypertension, it's recommended that they actually get a screening echo for the evaluation of liver transplant and transjugular portosystemic shunt. Another one, so CTEPH, remembering that that's when patients have a chronic PE. If somebody's been treated for that PE and they go on to have symptoms, that's when you can do an echo in the workup as part of CTEPH. They're going to go on to have other studies as well. But again, if you're thinking about what do we have easy access to, echo is one of the things we have easy access to. And then lung disease. So if pulmonary hypertension is suspected in patients with lung disease, it's recommended that an echo be performed. And you might say, well, why? And I think it's, again, similar to the case that I presented, there's a lot of overlap in these patients. A lot of them have cardiac conditions, they're overweight, they may have some HFpEF. And so getting an echo on board and looking for these parameters is important. And that's it. Sorry, it was a little bit short, but that's kind of all I was going to discuss today. And I'll open up the floor for any questions.
So thank you, Priya. So I just want to mention a few things. There are currently 60 people signed on. So together with the people in the room, we have about anywhere between 75 to 80, actually 80 to about 90 sort of like participants in your round. So we did observe when the weather is cold, there's actually more people signing on. That's what has been observed. But also want to mention historically, you mentioned about the father of stress echo. So he's also the father of echo, which is Dr. Feigenbaum from University of Indiana. So he pioneered the initial paper as well as the digital stress echo that we are using today. When I started with stress echo, it was actually using tapes, and then later on was having a separate station, which is like a rack mount, which is about 150 pounds that we have to push together with our echo machine to digitize separately. So we have a tape machine, and then we have a digitizing station to do the optical discs. And later on, Philips actually integrated into the station. So it makes it much easier these days to do that. And then as far as Bruce protocol is concerned, anyone knows who Bruce is? They've been using Bruce protocol for a long time among the cardiology residents and echo fellows. You don't know? So it's actually Robert Bruce from the University of Washington, and he's considered to be the father of exercise stress testing. And together, he partnered with a company called Quinton. So you probably heard about the Quinton treadmill. The reason why the Bruce protocol is such that it's jumping with all the different steps is because the original one is actually a knob. So you have how many speed levels and how many grade level. So that's actually why this Bruce protocol is such a jump historically. But there's another protocol that Stanford came up with, and it's called the RAM protocol, but it's about 1 minute per MET, which you probably know is great for research because you're much more precise in terms of MET, but it takes forever to do clinically. So that's why we're still using Bruce protocol. So these are some of the historical sort of aspects to stress testing and stress echo. And my question is, what should we do with that patient? Now that you sort of like open up the Pandora box and we see this all day long, and then what do we do with it? Do we still tell them to lose weight? Anyone else? Because we do see that all the time, and often exactly how it ends up is like the BNP is negative, and they're often actually overweight. They are short of breath with exercise, and I do underutilize stress echo for these kind of patients. So actually, that helps me to think about these things in a different light.
I think it's probably multifactorial, and I think losing weight is definitely a component, but in somebody young and to not further work it up and just chalk it all up to weight is, I think, would be a disservice. And so I think this could be someone where at least refer them for consideration or do some further workup.
Okay.
I guess it's tough because there are several mechanisms to exercise-induced pulmonary hypertension. So it's a matter of what is their mechanism for that, and then testing for it's innocuous, and then treating exercise-induced pulmonary hypertension. We don't really have good treatments. It depends on the mechanism. So those are things you can elaborate on too, but that makes this patient population a challenge, obviously, to diagnose and treat.
Yeah, and to Mike's further point, like in terms of the mechanism, as we saw from the WHO classifications, it's the ones that have the real intervenable type. It's so few and far between. It's a very, very rare population. So, as you said, even if you diagnose this and you identify it, well, how many of them are actually going to go on to have pulmonary arterial hypertension and require a drug, or is it, I don't know. But it's one of those things that I wonder, are we missing a group of patients?
Well, we certainly often missed. So
I think what's interesting and kind of unique in that population too is if you get a lot of these people and you exercise right hard cath them, there is actually a good chunk of HFpEF patients that people are, I guess, patients that you would normally classify as just having HFpEF. And with right heart cath and exercise, they have an abnormal increase in their wedge pressure to cardiac output slope. So their wedge pressure goes up disproportionately to their cardiac output, which is what contributes to their breathlessness. But in a large proportion of them, they actually have disproportionate rises in their PA pressure, irrespective of their wedge pressure. So the wedge pressure might go up a little bit. Initially, you're like, oh, this is a HFpEF patient. You think it's group 2 pulmonary hypertension. But then with exercise, their PA pressure goes up disproportionately to their wedge pressure. And maybe actually there is more of a component in group 1 as well as group 2. And so I think that we're maybe under treating those patients a little bit because we assume a lot of this is just group 2, secondary to HFpEF. But when you actually exercise them and do the right heart cath with exercise, you can delineate that there's maybe more of a component to group 1 as well, and you can kind of treat them a little bit more aggressively.
And this is one of our colleagues at Mount Sinai, Dr. Susanna Mack's life's work. So,
Yes.
so thanks. Within U of T, we're very lucky to have actually a number of resources available to us in terms of pulmonary hypertension clinic by Dr. Granton, and then also Dr. Susanna Mack, who actually did a lot of work. So I'm actually interested in Brian's experience. You did a lot of work on exercise stress testing, and also with the now there's we have a new machine, CPAT. Can you comment on it? For these patients with shortness of breath with exercise, is CPAT useful versus stress echo?
Yeah. I'm actually not too sure from the CPAT perspective of the data, and that it's too bad Dr. Connolly just stepped out. So he could definitely be able to comment a bit better there. I think that there is an evolving field of using exercise to help delineate where this breathlessness comes from. So the whole database of patients that they have at TGH Mount Sinai is like a dyspnea of unknown origin, and trying to delineate whether or not it's secondary to HFpEF or underlying lung disease, or just secondary to resistance or compliance issues in the pulmonary vascular system. From the CPAT perspective, I mean, it would be helpful in actually just trying to delineate whether or not their cardiorespiratory fitness is down. And obviously from a heart failure standpoint, it's helpful. And there's probably some data in kind of the HFpEF and PH literature as well, but I'm not aware of it. I don't know if anyone else is, but.
Well, it's one of the area of active research. So
yeah.
It's one of the area that as cardiology people we're very weak in. It's, your case actually highlight exactly what we deal with all day long on the front line. So any other comments on the other side, Dr. Howard?
Anything. I guess the issue is bicycle versus treadmill in these patients. It would seem to me that bicycle is better. Doing this with treadmill, I would think is much more difficult to get data that is useful.
Yeah. So I mean, there are benefits and disadvantages of using the bike versus treadmill. I think for RVSP measurement as well as diastolic function assessment is easier, or because you can with the bike because you're continuously having it. And in our lab, we're very fortunate to have both. So you have to select which one wisely. And one of the challenges with exercise stress echo on the treadmill is that we typically get all the wall motion first, and then we do the RVSP. So that will be about 35 to about 60 seconds afterwards. So when the people sort of settle down and the blood pressure do come down. And I think there's some initial data that shows that the RVSP doesn't come down as quickly as we thought. So I think we still do that, but it requires tremendous amount of skill. We're trying to get that with stress testing using the treadmill. Of interest, the bubble study that enhanced the TRJ was written by Mass General by Dr. Picard. So having saline injection with RVSP enhancement, since we are going to do the contrast anyway, is actually another means because you have an IV already. I think most of our stress echo now is using contrast. We moved from 30% to 50 to 75, and now we're almost close to 100, or very close, unless the patient actually refuses.
Unless they re-advertise.
Yeah.
The other thing I'll just comment on what Dr. Howard said is there is good data that somewhere in the range of 15 to 20% decreases in VO2 output or VO2 max that you can get on a bike versus on a treadmill. So even if you're using the bike instead of the treadmill, you might actually not be pushing people as far to peak as possible, unless they're cyclists. Cyclists can match 1-to-1 from their bike and their VO2 on the treadmill, but so you might actually be not quite getting their peak RVSP because you're not quite getting them to peak because they're they reach their lactate threshold from their legs fatiguing prior to actually reaching their peak VO2 max on the bike.
Yeah, it highlights kind of what needs to be done, because presumably these are just symptom limited tests. Like, we're not trying to hit a max heart rate or anything. You're just trying to go until they get symptoms and they can't go any further, and then you take the measurements, right? And then we're seeing if there's an increase, but it's kind of subjective what the increase is. Like, there's not a hard cutoff. So hopefully we have more data in the future to help make this kind of more useful.
Yeah. On a day-to-day clinical basis, the bike certainly is more likely to have sub-maximal stress tests. We had a few early on this week.
Yeah.
Part of it is because with bike exercise, you actually focus on your quadriceps. So unless your quadriceps is trained, you often will fail and cannot do as much as you are on the treadmill. But the bike is actually useful on among patients who are paradoxically very fit, because those patients actually, once you exercise them, get the heart rate to 100% or maximal predicted heart rate, they drop the heart rate really fast. So often for very, very fit people, we will use the bike for that reason. And also for people with back pain. So it's easier for them to actually do the supine bike when they're back pain than exercise in the upright. So those are the things that, like, when we choose the bike versus treadmill, those are the considerations that we take into. And also for valvular cases, bike is better. So for years and years, we only have the bike, and it took about 15 years for us to introduce the treadmill for a variety of reasons. But now we have both, so you can choose it wisely.
There's a question in the chat. Yeah.
Oh,
yes.
yeah. 1 second.
So I can read it out. So in the case, do you consider ARHC to separate pre-capillary versus post-capillary heart failure with preserved ejection fraction? That's a mean.
Like heart cath.
Right heart cath.
And right heart cath. Okay.
In the case, did you consider a right heart cath? Yeah. So I think, sorry, I wasn't sure what ARHC is. I do think, so this was a case I saw. I'm originally from Halifax, and this was a case I saw, and this patient was referred on to have a right heart cath. It turned out actually to mostly be HFpEF, and it wasn't like group 1. But I think it illustrates why these patients should go on to develop, or should go on to be referred for right heart cath.
Yeah, often that's what we do as well, plus or minus exercise with right heart cath.
I was just saying, it's a good question, because like that, how many of those patients have we seen come to the stress lab, dyspnea, and we do an ischemia protocol? We don't look at the TR.
So that, and that's right, and that's a big thing. Why I think like this is underutilized, because I do think.
Am I wrong? What proportion of
well, I think, when you're referring on to stress echo, you have to specify it specifically for shortness of breath protocol. Then we'll have to increase our RVSP and RV assessment. So whoever is referring, you have to spell it out, and I do that. For some of my patients, I would actually specifically ask for RVSP.
Gene has a question.
Gene has a question on the back.
I've been using ultrasound enhanced agent, not only enhance the report definition, but also sometimes enhance the number signal, stenosis, RVSP. I can't remember the last time I used resaline to enhance the gear jet, so I use the ultrasound enhancing agents. So my technique, though, because sometimes it would falsely elevate or increase the signal, I use the maximum reject. It's a GE, it's a Philips maximum. Again, it's reject. So there are 2 settings to maximize that. On Philips, I can show that.
Yeah.
I may need to repeat that. I don't think you're going to.
So I'm just going to repeat it very quickly. Being one of our senior sonographers has commented on the fact that not only agitated saline contrast can enhance the TR envelope, but also ultrasound enhancing agent, i.e. echo contrast, can also enhance the envelope. But you have to be careful not to overestimate it by making sure that you use the maximum reject button on either the Philips or the GE machine. So those are some of the technical tips. Very helpful. Great. Grace, you have some comments as well?
Based on the previous talk, so using the saline is what they say they will be using. Can you update the contrast to the saline?
Well, that's what Bean is commenting on, the fact that you could. But often what I find is that the signal is so much
Yeah.
That you overwhelm the TR signal. That's the problem.
So with the technique with stress echo, if you're looking for RBSP and we use contrast all the time to all our patients. But again, in the valvular case, we try and see if what we're focusing more on Doppler signal or RBSP, then we try to avoid the contrast. But just in case you have used the contrast and you're seeing that there is a potential increase in RBSP, so let's say you're getting into the HIIT exercise, just use that over contrast to get those RBSP parameters first before you get the LP. That's it.
Do you have a sense of how much it over exaggerates the TR max velocity? I don't know if there's literature published on this, but how much does contrast cause the Doppler signal to be exaggerated? We're talking like 10%, or we're talking.
Again, even just by measuring the TR jet, so you're already overestimating the signal, right? Because sometimes where are you gonna put that cursor? Is it on the far left, far right, or in the middle of the Doppler envelope? So I try to avoid the edges because that's where the spikes. With the CW, you'll see the spikes. So I'll try to go in the middle. And so when I'm taking that Doppler signal, I'm trying to again play around with the alignment, and then also making sure that I have that Doppler signal envelope in at least measurable in the middle.
And how much the volume? Like, when you're doing the sailing, you essentially should like 10, 60 or 5 or more, right? But with contrast, we only inject like cc or not as much as the saline. So does the volume of the saline affects the intensity of the jet, the jet, or not really?
Oh,
Probably, but
Probably not. We'd be talking about.
it should affect the density. I thought Dr. Lampoy always said that, the contrast will make the color jet look more prominent and wide and crazy.
Yeah,
right?
yeah, it does.
But I thought the max velocity was unaffected.
Yeah, it shouldn't be affected if you optimize it properly.
Yeah, it'll make the signal look more dense, but it shouldn't make the maximum velocity. Oh, yeah.
Yeah, I actually did a quick little review. There's actually a gentleman by the name of David Platts from Australia actually wrote a paper on this using using echo contrast to enhance TR jets. So it could be a research study, a very simple one that we can repeat. Kathy, you have the last words. We are up to 9:58, 9 o'clock.
Like I've experienced trying to get a TR with the models with saline and Infinity or SonView, whatever. But I prefer doing the full sun enhancing agent. When I do my TR or even color to make sure, to enhance the colors, I turn off the contrast. I go off contrast protocol, so you inject the contrast and go off contrast protocol. Make sure you're really, you're showing your jet right before you put your cursor, and also have to be part of the flow. And I just play around with either, as Bill said, the gain, reject, compression, and all those controls, so you don't kind of overestimate and also underestimate. Just enhance the signal.